Welcome back again. Hello everyone. We will speak about bladder tumor part 4, part 6. We will speak about stage T2, 2T4A, M0, M0, M1, N1, M0, and M1. Intravascular therapy is not effective for stage T2, 2 and 3 and 4. Radical cystectomy is the preferred treatment for most patients with M0, muscle invasive bladder cancers, so it is gold standard. Radical cystectomy is preferred with urinary diversion and bilateral lymph nodes, bilateral pelvic lymph node adenectomy. Neoadjuvant systemic chemotherapy before radical cystectomy is recommended. In select cases, post-operative pelvic radiation may be utilized. Okay, but they recommended to do chemotherapy before radical cystectomy. Neoadjuvant systemic chemotherapy with cisplatin-based regimens is recommended before cystectomy. Because the randomized trials have shown that they achieve 5% absolute improvement in 5 years overall survival and 9% absolute improvement in 5-year disease-free. This is the neoadjuvant systemic chemotherapy important with cisplatin-based is show 5% absolute improvement in the 5-year overall survival, so it's 5%. And 9% is absolute improvement in 5-year disease-free survival. Initiate neoadjuvant chemotherapy with 8 weeks of the cancer diagnosis. So neoadjuvant chemotherapy within 8 weeks of the cancer diagnosis. After neoadjuvant chemotherapy, perform radical cystectomy as soon as possible. Ideal with 8 to 12 weeks after finishing chemotherapy. If the patient is not eligible for cisplatin-based chemotherapy, proceed directly to radical cystectomy. Do not administer carboplatin-based regimens instead. Okay, this is the patient not eligible for cisplatin-based chemotherapy. Directly go to the radical cystectomy and do not use carboplatin-based. Neoadjuvant radiation is not recommended for T2 to T4 tumors. If neoadjuvant systemic chemotherapy is not given, radical cystectomy should be performed within 3 months of the cancer diagnosis because operating beyond 3 months increase the risk of progression and risk of death from the bladder cancer. That if the neoadjuvant systemic chemotherapy is not given, so you can do the radical cystectomy, the urologist will do radical cystectomy. This should be performed within 3 months of the cancer diagnosis because operating beyond this increase risk of the progression and cancer death from the cancer, bladder cancer. Also, consider adjuvant chemotherapy when the surgical pathology show extravascular extension, that is stage 2 BT3 lymphovascular invasion or lymph nodes metastasis. If this is available or if this patient have this pathology, so consider adjuvant chemotherapy when surgical pathology show this after radical cystectomy. For adjuvant systemic chemotherapy, there are no randomized trial of adequate size to prove a benefit, but a non-randomized study show that it is lower recurrence rates and improve overall survival. Neoadjuvant chemotherapy is preferred over adjuvant chemotherapy based on the higher quality of evidence. Radical cystectomy without chemotherapy can be utilized for patients not eligible for cisplatin-based chemotherapy. The preferred chemotherapy regimens for either neoadjuvant or adjuvant therapy is either DDMAF, VAC, that's dose dense methotrexate, vinblastine, adriamycins, and cisplatin is known as DD, that the dose dense MFAC, that means methotrexate, vinblastine, and adriamycin and cisplatin, or the another regimen is known as GC, this is gemcitabine and cisplatin. Substituting carboplatin for cisplatin in this setting is not recommended because it reduces response rate and survival. I mean, all cisplatin-containing regimens should be utilized. Post-operative pelvic radiation, patient with extravascular extension stage more than BT3 have a high risk of pelvic recurrence and lower overall survival, even when preoperative chemotherapy is added to radical cystectomy. There is minimal data on use of post-operative radiation, but some data suggests that it may decrease local recurrence and improve disease-free survival. The NCCN 2021 NICE guidelines state when there is no conclusive data demonstrating improvement in overall survival, it is reasonable to consider adjuvant radiation in patients with PT3 and PT4 and BN0 to BN2 urothelial bladder cancer following radical cystectomy. This is for patients that have actually that have the patient have patient with PT3 and PT4 with lymph node or without lymph node urothelial cancers following radical cystectomy, we can consider adjuvant after radical cystectomy. Pelvic radiation may also be considered in patients with positive surgical margins. So pelvic radiation is also in patients with positive. Post-cystectomy pelvic radiation is typically restricted to the patients with conduit urinary diversion. So the patient with conduit urinary diversion restriction must be advised. A new bladder or catheterizable content diversion would likely suffer too much radiation damage to make radiation a feasible option. Bladder sparing treatment, this treatment preserves most or all of the bladder. Thus, urinary diversion is unnecessary. Bladder sparing treatment are typically used for patients who elect not undergo radical cystectomy or patients who are unfit for either radical cystectomy or urinary diversion. Bladder sparing surgery is less effective in patients with any of the following. If the patient have a large tumor in which TURBT cannot resect it, all grossly visible tumors. So this is the first criteria. Large tumors, which that the TURB cannot resect all gross visible tumors, or the patient is stage T3, or the patient is stage T4 cancer, or the patient have multifocal CIS, or the patient is extensive CIS, or the patient have hydronephrosis that caused by bladder cancer. All this is considered that the bladder sparing surgery or therapy is less effective in patients with this criteria. Okay, patient with large tumor in which TURBT cannot be resect all the gross visible tumor, or also the patient is stage T3 or patient stage T4, or patients have a multifocal CIS or extensive CIS, or the patient have hydronephrosis caused by bladder cancer. For this patient, bladder sparing therapy results in relatively low cure rates and substantial risk of needing salvage cystectomy. Maximal TURBT with chemoradiation, that is known as trimodality therapy. Trimodality therapy is more effective than other forms of the bladder sparing surgery. If the patient wants to retain their bladder and is eligible for chemoradiation, then trimodality therapy is preferred form of bladder sparing treatment. Partial cystectomy only an option in selected patients. Based on a study of the patients undergoing radical cystectomy, neoadjuvant chemotherapy is recommended for the patient undergo partial cystectomy. Partial cystectomy alone may be used in patients who are not eligible for systemic cisplatin-based chemotherapy. Also, post-operative pelvic radiation may be considered in situations that are similar when we use for radical cystectomy. If we have positive margin, for example, we can give the patient radiation. Maximal TURBT with pelvic radiations, the maximal TURBT with pelvic radiations used when the patients are not eligible for systemic chemotherapy. Maximal TURBT with systemic chemotherapy used when the patients are not eligible for pelvic radiation. TURBT alone less effective than trimodality therapy However, TURBT alone can help control local symptoms in patients who do not want or cannot tolerate systemic chemotherapy or pelvic radiations. Example of the following follow-up regimen for patients with T4, T2, T3, T4, or N0, and N1 and 2, M0. We will do chest imaging, CT or chest X-ray or CT urogram and urine cytology. This must be done every 3 to 6 months for 2 years and then annually. Okay, all this image is as an option, chest imaging that might be chest X-ray or chest CT. Chest X-ray at first, and then if we have abnormality, we can do CT chest, CT urogram, it's the best choice, and urine cytology. This must be every 3 to 6 months for 2 years and then annually. CT urogram is preferred in most cases, but the other image alternatives are available. Serum LFT, electrolytes, blood urea nitrogen, creatinine, and CBC if the patient has systemic chemotherapy. This must be done every 3 to 6 months for 1 year, then annually. As you see here, we'll do imaging for every 3 to 6 months for 2 years, but the lab, it is every 3 to 6 months for 1 year. Then annually, here we have every 3 to 6 months for 2 years, then annually. All right? Well, this for imaging and this for labs. After radical cystectomy, if the patient's if the urinary diversion contains significant links of the ileum, obtain B12 supplement, vitamin B12 levels. This must be also done yearly, each year. For patients with retained urethra, perform urethral wash cytology with or without ureteroscopy every 6 to 12 months. We would like to do ureteroscopes, that's every 6 to 12 months. Okay? Consider visualization of the urinary diversion, example endoscopy or pauchogram when the urine cytology or imaging suggests recurrence with the urinary system. After bladder-sparing cystoscopy and urine cytology every 3 months for 2 years, then every 6 months for 2 years, then annually. Then we will come to the last part of this lecture, stage T4B, that's N2, M3, M0. Initial treatment typically consists of systemic chemotherapy. When the systemic chemotherapy is sufficiently downstaging the disease, then the radical cystectomy or trimodality therapy may be offered. When the local tumor is causing problematic symptom like significant gross hematuria, so this and then extended beam radiation may be utilized for local tumor control. Here we have stage M1. Initial treatment typically consists of systemic chemotherapy. External beam pelvic radiation may be used to control cancer-related symptoms such as significant gross hematuria for patients who are without rapid cancer progression and who have few residual metastatic lesion following systemic chemotherapy. Limited data suggests that excision of the metastasis can achieve long-term survival. This is the end of the bladder tumor.